Last week, a senator stands at a podium and declares that a common medication is 22 times more dangerous than the FDA's own data shows, and introduces a bill to pull its approval entirely. By the end of this video, you'll know where that number came from, how the medical community responded to it, and why this debate matters beyond the abortion question. Whether you're pro life or pro choice, I'm not here to tell you what to think, but to help you think for yourself. Let's get into it. This bill is built on a specific number, so let's start there. A 2025 study by the Ethics and Policy Center claimed that the serious adverse event rate of mifepristone, one of the two drugs used in medication abortion, was 10.93%. That's considerably higher than the SAE rate reported by the FDA of 0.05%. The study framed this as mifepristone being 22 times more dangerous than previously reported. Mifepristone works by suppressing the hormone progesterone. When you get pregnant, progesterone increases to tell your uterus not to contract. It's why you stop getting periods. Imagine the uterus is a little paper sailboat, and progesterone acts as an anchor. Mifepristone acts as a pair of scissors, cutting the connection between the sailboat and the anchor. Now, if a big wave comes through, the sailboat is at risk of tipping over and spilling its precious cargo. This is where the second drug comes in. It triggers a big wave that tips the boat. In short, mifepristone blocks progesterone, softening the cervix and breaking down the uterine lining. Then, misoprostol, taken roughly 12 to 24 hours later, triggers contractions to expel the pregnancy. Now, I don't want to downplay it. By most accounts, the experience is described as significantly more intense than a typical period, and it tends to be worse the further along the pregnancy is. I have known a few women who had medication abortions, and I have heard them talk about what the experience is like. But it doesn't cause your uterus to do backflips or anything. These mechanisms are the same ones your body uses to expel its uterine lining once a month, or in a spontaneous abortion or miscarriage. For this reason, medication abortions tend to be highly effective, but serious adverse events such as hemorrhage or infection can occur. Understanding those risks is important because the safety debate is really an argument about how often this process goes wrong. Because the process intentionally breaks the connection between the pregnancy and the uterus, heavy bleeding is an expected part of the process. Imagine pulling a scab off a deep wound. You expect it to bleed until the body clamps down on the blood vessels. Normally, the uterus squeezes tightly shut after the pregnancy is expelled to stop the bleeding. However, if the uterine muscles fail to contract, a condition called atony, or if a piece of pregnancy tissue gets left behind, like a wedge holding a door open, the blood vessels cannot properly close at all. This can lead to severe, uncontrolled hemorrhage requiring a blood transfusion or emergency surgery. During a medication abortion, the cervix must soften and open to let the pregnancy pass. Think of it like leaving a front door open in a storm. Bacteria that normally live harmlessly in the vagina can travel up through this open door and invade the uterus. If any dead pregnancy tissue is left behind, it acts like spoiled food left on a kitchen counter, providing a perfect breeding ground for bacteria to multiply. In very rare instances, specific bacteria like Clostridium sordelli can trigger a life-threatening immune reaction called exotoxic shock or sepsis. Finally, if the pregnancy is ectopic, meaning the embryo implanted outside the uterus, often in a fallopian tube, mifepristone won't affect it. Ectopic pregnancies require surgical intervention so that they don't explode your guts. Okay, so we know this drug triggers your body's natural processes and that there are instances where things can go wrong. So, what did the Ethics and Policy Center do differently from the FDA to get such a different number? There are three specific methodological choices the study made that sit at the center of this debate. For each one, both sides have a case worth hearing. Where the FDA looked at highly controlled clinical trials involving thousands of carefully screened patients, instituted mandatory reporting rules, and conducted repeated comprehensive interviews over 25 years, the EPPC study looked at insurance claims. Any abortion-related emergency room visit was counted as a serious adverse event. This is called methodology. And when scientists review competing studies, methodology is one of the first things they examine because different approaches to measuring the same thing can produce very different results. Problem number one, how the study conducted emergency room visits. To understand why this matters, imagine a researcher trying to find out how dangerous a school playground is. To do this, they count every single child who visits the school nurse after recess as having a severe, life-threatening injury. In reality, many kids just wanted a Band-Aid or a place to rest a mild stomachache, and only a rare few actually broke a bone. Critics of the EPPC study argue something similar happened here, that many of the ER visits counted as severe adverse events were precautionary check ins rather than genuine emergencies. Mainstream medical experts emphasize that an emergency room visit alone is not evidence of a complication. The EPPC authors push back on this. They point out that they actually excluded 72% of the ER visits within 45 days, specifically those involving diagnoses unrelated to the abortion or that weren't medically serious. They argue their approach was conservative, not permissive, and that they applied strict National Institutes of Health criteria to count only severe grade 3 and life-threatening grade 4 events. That has to do with how the treatments are billed to insurance. It's related to insurance coding. Problem number 2, how the study classified follow-up procedures. The study counted the use of a follow-up procedure to clear remaining tissue as a severe adverse event. The two procedures are known as uterine aspiration or dilation and curettage. These abortion medications trigger a biological mechanism that already exists, the same one that induces miscarriages. Nothing in nature is perfect, though, and any expulsion of a pregnancy carries a risk of being incomplete. Between 3% and 5% of medication abortions require a follow-up surgical procedure to clear remaining tissue, and the EPPC study classified each of those as a severe adverse event. The medical consensus treats a follow-up procedure as a standard and expected part of the process, not a complication. Uterine aspiration is considered one of the safest procedures in medicine, and is viewed by the medical community as just a different path to the same safe outcome. Proponents of the study raise a fair point here. Their dataset analyzed over 865,000 insurance claims, roughly 28 times larger than all the FDA clinical trials combined, and using much more recent data. They argue that the FDA trials relied on carefully screened patients in controlled settings, while their study reflects what actually happens when average patients take this medication at home, sometimes without direct medical supervision. Critics acknowledge the dataset is large, but argue that the size doesn't compensate for classification problems, particularly because the study's largest category of adverse events, making up more than half of all counted complications, was vaguely labeled other abortion-specific complications. That's kind of like when you're moving and you just have a box labeled stuff and you just throw a bunch of stuff in there. That category problematically included diagnostic codes for natural miscarriages, going back to what we said about those insurance codes, meaning the study may have been counting complications from miscarriages and attributing them to the drug. And problem number 3, peer review. One of the most common criticisms of the EPPC study is that it wasn't published in a peer-reviewed journal, meaning it wasn't independently evaluated by other scientists before being released and cited by the congressman. Proponents address this directly. They argue they prioritize replicability over traditional peer review, making their full methodology public and using a dataset available for purchase so any independent researcher could verify the results themselves. Critics counter that this transparency is incomplete. The authors did not disclose the specific dataset they purchased, nor the exact medical diagnosis and treatment codes they searched for. Without those details, true independent replication isn't actually possible, and the claim of openness doesn't fully hold up under scrutiny. Both sides agree transparency matters, they disagree about whether the EPPC delivered it. Though there have been a small number of exceedingly rare but fatal cases of toxic shock syndrome following mifepristone use, experts and the FDA note that there is no direct causal link between the drug itself and the bacteria. The infection is likely related to the physiological process of the cervix opening and tissue passing, as similar fatal infections have occurred after natural miscarriages and childbirth. The EPPC study categorized these cases along with ectopic pregnancies, which mifepristone does not cause and cannot treat, as complications of the drug. When looking at mortality rates, a medically induced miscarriage and a natural one are virtually identical. However, there is a stark difference in complication rates when comparing properly supervised procedures to those performed without medical oversight. To understand how outcomes differ based on the conditions under which a procedure is performed, researchers have compared results across different settings. A comparative study in Cameroon, where restrictive laws lead women to seek procedures outside of medical facilities, found that in settings where medical training and sanitation are lacking, women were over 4 times more likely to develop sepsis, twice as likely to need an emergency blood transfusion, and significantly more likely to experience fever compared to women having spontaneous miscarriages. Interestingly, the exact same medications used for medication abortion are widely considered the gold standard for managing miscarriages miscarriages when the body does not fully expel the tissue on its own. When used for miscarriage management, this regimen has a safety profile comparable to or superior to other alternatives like surgical intervention or simply waiting for the tissue to pass naturally. This is worth keeping in mind when following any debate over medication or procedure. Understanding the full range of its uses gives you a more complete picture of what's being discussed. Beyond abortion, mifepristone has several other approved and off-label uses worth understanding. It is FDA approved to control high blood sugar in patients with a specific type of Cushing syndrome and to help regulate dangerous elevations in cortisol. It is sometimes prescribed to reduce the size of uterine fibroids, which are scars on the inside of your uterus, and to treat endometriosis. It's also been used to help induce labor in pregnant women. Since its FDA approval in 2000, over 7.5 million women in the US have used mifepristone. The mortality rate associated with the medication is estimated at less than 1 in 100,000, making it as safe as a natural miscarriage and significantly safer than childbirth or commonly prescribed medications like penicillin. So here's where the evidence stands. The science on mifepristone has been studied for 25 years across millions of patients. The debate over that one study's methodology doesn't change the 25-year body of evidence, but it does illustrate how the same data can be interpreted very differently depending on how a study is designed. What makes this debate useful as a case study is that both sides are making arguments about methodology, not just trading accusations. The EPPC points to a dataset size and real-world conditions. Critics point to classification standards and incomplete disclosure. Neither of those is a simple thing to dismiss, and that's exactly why understanding how a study was designed matters more than just reading its headline number. Knowing how it was designed and what it actually measured is the most important tool you have as a news consumer. During the announcement introducing the bill, Rep. Diana Harshbarger made several claims that cast some doubt on the accuracy of the FDA's data. That is a whole deep dive of its own, so subscribe and turn on notifications so you'll see when that video is posted. In that video, we'll also be taking a closer look at what the bill does exactly, because even though the full text of the bill Hawley introduced hasn't been made available yet, we have a previous version of the bill we can look to for some idea of what to expect.